Before we get into it, a brief word about NovoPsych, which is proudly hosting tonight's webinar. NovoPsych is designed for mental health clinicians to administer high-quality standardized questionnaires efficiently to support measurement-informed practice. We host these trainings like this so that we can help clinicians enhance their clinical assessment and think more deeply about the way they assess. We have over 150 assessments in the NovoPsych test library, and we're really proud to have collaborated with Dr. Marianne Kate on the mid-60 for a few years now. Now to our presenter. Tonight we're joined by Dr. Marianne Kate, an award-winning researcher and lecturer specializing in trauma and dissociation, and the creator of the multidimensional inventory of dissociation, the 60-item version, including the adult and adolescent versions of the mid-60. Marianne is currently the chair of the scientific committee of the International Society of the Study of Trauma and Dissociation. She's supervised dozens of honours students on dissociation-related projects over the last few years, and it's been my absolute pleasure to have collaborated with her on some of those projects. Welcome, Marianne.
Thank you.
And so we've known each other for like 3 years now, and we've been collaborating on research with the mid-60. And I must say, I don't think I've met a more passionate researcher who puts more blood, sweat, and tears into it. Your research output has been incredible. And what I wonder is, why are you so passionate about researching and teaching people about dissociation?
I just think that there's so little known about it on the whole. The training really isn't there. It's often the chapter that's skipped when people are doing their clinical training or their undergraduate degrees. There's often psychiatrists who are sort of very much from the 1990s model of thinking, oh, it doesn't exist, and have kind of ignored the last 30 years of rigorous evidence and all these incredible neuroimaging studies, and so there's this like controversy that sort of continues, and I don't think it really should. Like, if people actually looked at what the body of evidence was, then that would be more on board. And we're going to talk quite a bit about prevalence, and as you were saying, about how transdiagnostic it is. And often clinicians say to me, I've never had a client with dissociation. And they're often quite confident in that, but I'm not. I get the sense that they have seen probably numerous clients, and often they're ones that maybe are the most challenging, and they can't quite work out, is it, complex PTSD, is it bipolar? I think there's some borderline, is it schizoaffective, major depression. So, yeah,
I think that in our audience, I've asked the poll question, what's your level of experience with dissociation in clinical practice? And we do have a few people that said they haven't seen it at all. But it is interesting. Most people are sort of indicating that they've seen it, but they've only got a little bit of experience. So the experience levels are pretty low. We do also have some people with moderate experience here and some very experienced people as well. So some people across the experience spectrum. And I must say, when I last did some training with you and saw your work, it took me from being very inexperienced to maybe having a little bit more knowledge. So, and I hope that you'll do the same for our audience tonight. So Marianne, I'm going to pass across to you, and I might have some questions for you throughout.
Great. So what is dissociation? It's this disconnection between the person and aspects of their own human experience. So these feelings and experiences can be fleeting, they can endure for a while, and for some people they'll last a lifetime. So it's all about this disconnection, this fragmentation, this compartmentalization. So the person's becoming disconnected from, it might be their memories, their emotional state, their behaviors, their thought process, what's going on in their body, this sort of somatic experience, and their identity, their very sense of self. And dissociative disorders become diagnosable when there's a clear disruption or discontinuity in what we would see as the normal integration of consciousness. So memory, identity, emotion, perception. So that's our APA definition of it. So dissociation, in the way that I view it, it's a strategy and a really effective strategy that enables people to endure through traumatic and stressful events that would otherwise overwhelm their internal resources, their capacity to cope. Dr. Colin Ross says dissociation provides the illusion that everything's okay. This isn't some Pollyanna view. It's about it being bearable, about it being manageable. So it might be the child that's with their abusive caregiver and they can't escape. They're reliant on their caregiver. They need their caregiver. They want love from their caregiver. So they need to find a way to be okay with what's happening. And this compartmentalization can help with that. And we see this also in situations with intimate partner violence, or it could be, you know, being sort of in a prisoner of war kind of situation as well, and a lot of circumstances that some refugees might be in. So the 5 key dissociative symptoms, and this is from Marlene Steinberg. So we talk about memory problems and amnesia, and that can be very broad. So difficulty recalling personal information. I think we can all have some difficulty in that, but this is often more extensive autobiographical histories. It can be people not remembering years of their life. For example, I don't recall at all when I lived in, you know, that town between the ages of 9 and 11. No memory of that. So depersonalization is where the self doesn't feel real, might feel really robotic and disconnected, feeling like a stranger. And then there's derealization, which is the world around is feeling unreal. And even people that you should know really well might feel unfamiliar. Everything might seem a bit weird and distorted. And then there's identity confusion, like people with dissociation really struggle about their sense of self because it's been quite fragmented about who they actually are. And in its more extreme form, you'll see also alterations, like with this fragmentation where a person is acting as if they were a different person to what you might expect. So for some diagnoses like dissociative amnesia, you just need that one. So it just might be dissociative amnesia. But for a person with dissociative identity disorder, and we will get into this later, they will have all aspects of this. So 6 reasons why it's important to identify dissociation. I did touch on that one. It's really common. People don't believe me when I say how common it is, but if you look at epidemiological studies where they just go around the general population and do clinical interviews, then we're going to find around about 10% of people in the course of their life will meet criteria for a dissociative disorder. And that might be a milder one like dissociative amnesia or depersonalization and derealization. It's a bit higher in university students, and we would expect it to be high in clinical populations. And that's what we see. Like, although the rates vary a lot across setting and country, that it's not like if you're in clinical practice, you look at the rates here and you know, some of them up to sort of 46%, but even at the lower rates of, I think 5% is the lowest, it would be expected that you would have come across a client that would have met the criteria at that time. And there's also really high rates for adolescents in this, and we'll go back to that. Something to watch. So dissociative disorders are just frequently overlooked, and that was one of the things that we talked about. So clinicians don't regularly assess for it, and it's a diagnostic blind spot because the person themselves is going to really struggle to articulate what's going on for themselves, and their own internal experiences are really complex. And sometimes people are just really embarrassed. They've got a lot of shame about what they experience. So it's difficult for them to be clear. And what we know is for people with complex dissociation, that generally they've been in the mental health system for about 7 to 10 years before they're diagnosed. So I've been working often with different people in different settings, and it's still not actually being picked up. So Ben was talking about the fantastic research that we've done with NovoPsych using my honours students and my research assistant, and some of what's come out has been really about, well, it's been my wish to have a stronger sense about, well, where are, what clients have dissociation? Because, the 10% is, people that also have other diagnoses as well. And so what we saw is like OCD, ninefold risk of having a dissociative disorder with those clinically significant symptoms, and sixfold for anxiety, fourfold for depression, and then threefold for disordered eating, but 14-fold for males with a eating disorder or disordered eating. And then we say sort of, at least a twofold risk for body dysmorphia and generalized anxiety, which may not sound as much, but it's actually incredibly significant on its own. We move into neurodivergent presentations and fourfold for autistic traits. But if we make the comparison group to people with really low autistic traits, then it's 12-fold. And tenfold for ADHD symptoms of the combined type, a bit less for hyperactive and attentive. But you get the feeling when you look at that there's a lot of dissociation out there, and it's just that the other presentation is what's being treated. The other part about it is like people don't often improve. And we know that standard treatment, so, the PTSD might be picked up, for example, which is most often comorbid, but the CBT is going to have higher dropout rates, not be as effective. And if you're looking at exposure therapy, things can actually get worse. It can exacerbate symptoms. And because of this being a known thing, that's one of the reasons, or a key reason, that in the ICD-11 we saw the introduction of complex PTSD to address this kind of dissociation, as well as in the DSM, them introducing depersonalization and derealization as a subtype of PTSD. So it's serious. I'm putting this here because I'm guessing I have quite a few EMDR practitioners. And so this is from Francine Shapiro herself, where she talks about the biggest harm and the things that go wrong in EMDR. The most concerning things are with people with dissociative disorders, and it often hasn't been recognized. So there's this potential for harm. But there's also, if the protocols are adjusted for dissociation, then there can be incredible gains. So it can be a real tool. So, seeing EMDR practitioners not be afraid of this, but, learning, getting additional training in treating dissociative disorders. It's also just really difficult. Life is incredibly difficult and challenging for people with dissociative disorders. So if it's missed, we can have more hospitalizations, self-harm, suicide. People often will talk about people being treatment resistant when it's just they haven't been given the right treatment, and because of the dissociation, the treatments aren't working in the way that's expected. And one of our students who early led research with who does was finding that dissociation explained 32% of the variance in overall disability, which is massive. And again, just that risk. So for people with dissociation, 5.5 times more likely to have functional impairment in daily life. Could speak for days on this, so I'm going to try to be very focused because I know we don't have lots and lots of time. Um, so childhood trauma is, often we talk about ACE scores, and ACE scores are really helpful, but they miss the severity and the age that it starts. And what we see with dissociation is it often starts really, really young. And there's also, because of that age, there's hundreds, often thousands of episodes of abuse. What we often see is like sexual abuse is a particularly strong predictor, as well as for females, it's this severe physical injury. And if we combine those, and for people that have experienced choking and smothering and sexual abuse together, then we're looking at nearly 100-fold risk of dissociation. So it's very much sort of dose dependent, not just simply trauma causes dissociation, it's this ongoing trauma. For males, sexual abuse and emotional abuse seem to be more predictive. And parent-child dynamics are the other part of that. So where there's abuse going on, and um, nearly always, if there's dissociation, I think every single case had some level of abuse, that people had reported some level of abuse. But if they're not in a family environment where the person feels, as Dan Siegel would say, feeling safe, feeling seen, feeling soothed, if they, they would answer questions like that they don't feel lovable, they don't feel they matter, they feel that they're worthless. So having this kind of messaging is really predictive of a dissociative disorder, as well as like the parents not responding when the child was hurt and unwell. And that seemed to be predictive, particularly like for males if it was their father, and for females it seemed to be more related to their mum. But it was just having that, not having those good experiences. And when we looked at the clinical sample, they had very, very few. They may have had the similar negative, so the negative experiences of parenting may have been the same between the university group that I looked at and the clinical group, but the clinical group just didn't have the goodness to draw on to get through it. And this was really apparent. I did interviews with women with dissociative identity disorder, and particularly the mother figure tended, that they were really sort of like cold and uncaring. And that's my words, because often the people themselves, they were actually sort of defending them in a way. But yeah, there was definitely not this warmth and this care. And this goes to the reactions also after abuse. So where there had been abuse, often there would be blaming. That is like a really common, for some people, the other parent might incite abuse. So this really negative, as well as non-protective parents. So, that came through as well, but there was actually also this very negative dynamic. And that also makes it awful that a person has to go through that experience and then have that response from a caregiver, but it also means the abuse is less likely to stop. And so that can also compound it. So like Jennifer Fried developed this theory called betrayal trauma, and where it's about the logic of forgetting child abuse that's perpetrated by somebody you're dependent on. And that is the way that they're able to continue, is to dissociate that abuse from their conscious awareness. But we can also track back longitudinally, which is fascinating, and in infants. So if an infant has what's called a disorganized attachment style, so there's sort of they find it really hard they can't go towards, they can become a little bit stuck, they have unusual movements when their mother figure returns to the room after a period of separation. They're not They're not really quite able to connect. And this behavior is seen to be like a disorganized pattern. It's called a disorganized pattern, and they call it a fright without solution. It's where like the infant's like afraid and they want their caregiver, but their caregiver is their source of their fear, so they can't win. It's the fright without solution. And it would seem that dissociation is a way of resolving that fright without solution in the moment, to be able to go toward the caregiver, to be able to, be with the caregiver who they're completely reliant upon as an infant. And we see that relationship between disorganized attachment and fearful attachment goes through childhood and adolescence, and we also see it in adulthood. And so in my questionnaires with university students, it was interesting that people with dissociative had a fearful attachment style, but they really wanted to attach. They were just really scared. And less so, a bit less, was the profound mistrust, where they were just like, I can't trust anyone to do it. So they again had that sort of conflict between wanting to go towards this relationship and it being too fearful to do that. So we're going to have a look at the dissociative disorders. We'll focus on dissociative identity disorder. I'd love to see this all reframed into like something called trauma psychology or adaptive psychology, and it called dissociative identity response, but it's not. So I'm just using the language we have here. We'll look at other specified dissociative disorder because it's an important category with the name that does not effectively communicate how important it is as a disorder, as a diagnosis. Dissociative amnesia, depersonalization, and derealization. Unspecified is usually emergency room, so I won't be looking at that. It's when not enough information to say and you need to make a decision quickly. And then we've got the ICD-11, big stars for the ICD-11. We've got complex PTSD. And one of the other great things that it did is bring partial dissociative identity disorder in, and we'll look at that as a diagnosis. It's a really important diagnosis in our field that's not in the DSM. And it also has neurological symptom disorder. So in Europe, they tend to see somatic dissociation, like conversion symptoms, like not being able to see as if you're blind, having difficulty walking, even though there's no medical cause for that. So these conversion symptoms are seen as sort of in the dissociation umbrella in Europe, where they're sort of separated out in the US and Australia. So what is dissociative amnesia? So an inability to recall autobiographical information. And so it can be about, and often is about, a traumatic event, but it could also relate to the time around that event or just a specific aspect of it. And for some people, it becomes generalized to, a lot of life where they really they struggle to be able to recollect things that you would expect them to know about themselves. And it might be, even getting married, for example, might not be in their conscious awareness. And this is without a medical, like when medical considerations have been excluded. There's one called fugue, and that's where people suddenly arrive in a new place and have no idea who they are or how they got there. This used to be its own diagnosis. It's incredibly rare, and usually it's actually dissociative identity disorder that hasn't been yet diagnosed. But that now falls under dissociative amnesia. So for dissociative amnesia, one of the important things that we have to unpick is whether the dissociative amnesia is actually part of post-traumatic stress disorder, because it's one of the diagnostic criteria for that. So we will look at a case and try to unpick about, well, is this dissociative amnesia enough in its own right to warrant a diagnosis? And then we have depersonalization and derealization disorder. And so this is experiences of unreality and detachment. So the person's observing themselves from afar, and there's often distorted senses of time, and they can feel really absent from their self. It's like that they're not there, and there can be the physical numbing of that. And then we have the derealization. So again, that's the detachment from the world around them, and often like foggy, lifeless, or visually distorted as part of that. So these are some of the things that a client might say that might give you a clue. And it's like, I am no one. They feel so detached from themselves. I have no self. And their emotions may be really quite absent. Like I know I've got feelings, I just don't feel them. And their thoughts, like the idea that their head's full of cotton wool and their thoughts don't feel like their own. And they can really lose touch with their bodily sensations as well, and have difficulty recalling memories. And like, so they may know the things that happened to them, but it may not feel that it happened to them as someone else. So sort of looking over those things as a sort of a not me kind of experience. Um, and they can also become really obsessed with, oh my God, do I exist? And this existential concerns. Am I real? And this fear of going crazy can be really intense. And like, oh, I've got irreversible brain damage. And it's interesting because we talk about this as the milder dissociative disorder, but for people that are experiencing it, it can be really, really stressful. And just this hypo-reactivity, so not reacting to emotional stimuli. And so they can also have sort of some somatic symptoms with it. So this tingling lightheadedness often accompanies it as well. So yeah, that's what you might hear. It's usually like not in children, it's usually more in teens, and you're not usually going to see it sort of after the age of 25. And for a dissociative disorder, it's not a trauma-based one necessarily. It's often life stresses. It might be a person losing their job, getting divorced, a number of things, and then their sense of self is questioned. Motor vehicle accidents are another one that this is quite common with, as well as people that are using drugs. It's really common afterwards for, MDMA and ketamine, for example, for people to experience this. All right. So this is a bit of the PTSD, dissociative amnesia. For some reason, dissociation seems to be more acceptable in PTSD than on its own. But negative alterations in cognition and mood, one of criteria D is an inability to remember important aspects of the traumatic events. And it specifically says typically due to dissociative amnesia. And then we need to work out if the symptom does it warrant a separate diagnosis? So looking at, well, what are the symptoms, and how does this relate to the PTSD diagnosis? And the other great thing is said we had in DCM5, we got the PTSD dissociative subtype. So it's weird that dissociative amnesia isn't in here. I don't know why exactly, but depersonalization and derealization, if they're present, then the person can be diagnosed with the dissociative subtype. So for dissociative identity disorder, previously known as multiple personality disorder. So the person has at least two separate personalities or alters. That seems quite a small number. Most people would seem to have more than that. But each part has different modes of thinking, being, feeling, and acting that's independent of each other. And that part is sort of in charge of what's happening when they're in executive control. So the person that is say fronting, most of the time might be totally unaware that they have alters, and that will be at least the case for some of the time. And they may have no memory or awareness of what the other parts of themselves were up to when they're not in executive control, like they're not driving in the driver's seat. And you do need to have amnesia as part of this diagnosis as well. So there's like this amnesia between the self states. So it's not like people think it's going to be really dramatic, but it often isn't. Hence why people are, seeing a clinician for 7 to 10 years before being diagnosed. And when things are really stressful, there will be a lot more sort of activity, a lot more sort of switching between different alter states. And the idea about, different self states that have like very strikingly visual differences isn't, that's more the minority. It's not the typical presentation. And often before diagnostically, the clinician had to actually watch and observe this behaviour to be able to say, look, I saw that there was a switch, but that doesn't exist anymore. It's just about being able to make sense of what's happened, listening and having enough evidence, but it doesn't have to be observed personally to make that diagnosis. Our next diagnosis, so this is a really important one, the main one that we focus on, and it used to have like another catchy name, dissociative disorder, not other specified type 1, but it is a sort of a subclinical type of DID, and I'm going to talk it through as partial dissociative identity disorder because it just makes it much easier to follow. But there's also other types, and so we've got dissociative trance, acute reactions, and sort of for people who have been, sort of in political sort of torture and cults, and they may sort of meet this second part of it as well. But one thing that I really don't like about the DSM is it says this category includes identity disturbances associated with less than marked discontinuities in self and agency, alterations of identity or episodes in an individual who reports no dissociative amnesia. They do. They report dissociative amnesia. What they're meaning is just they don't have amnesia for the self-state activity. So that's more what is the intention of that, but it's just worded really badly, and I think that it would make it hard to make a diagnosis. So that's why I really like switching to the ICD, switching to the ICD-11. So dissociative intrusions are very much part of this. So it's like thoughts and like experiencing fear, shame, and anger. Like you can have voices, there can be sensations that are attached to that, involuntary movements. So it's the person doesn't feel in control of what their experience is. So that's why it's called a dissociative intrusion. It's very ego-dystonic, aversive. It's a not me experience. However, even though there are parts, these parts don't take executive control of the person. And so I've explained this like in dissociative identity disorder, you have the person in the driver's seat and you've got a car full of the different alters, and there may be changes, but it's like through the driver. Generally, there can be a change of driver. And what happens in partial DID is that the person remains in the driver's seat and just experiences it as intrusions, and it might be really hard for them to stay in control, and they may feel very out of control but they're not losing the conscious awareness. It may not be as sharp as it normally would be, but it is being experienced more as an intrusion rather than actually fully moving, uh, taking a back seat and having a part step in, which would be the dissociative identity disorder. And so this can be they don't take executive control to the extent that they perform specific aspects of daily life. And so we see that in dissociative identity disorder. In parenting and work, there will be a particular part that's their job. That's the role that they're more responsible for. But you can sometimes see these like transient ones, and that's usually under states of extreme stress, or when traumatic memories are surfacing. So this may not be obvious for people that are observing it either. And this is what I was saying about the problem with the DSM, as it's do not experience amnesia during episodes of dissociative intrusion. So that's what's meant by dissociative amnesia. They're being more specific about it. So it is really important because this is 3 times more common than dissociative identity disorder. So it's the type that's most often going to be seen. And so the one part's functioning in daily life. There's still amnestic barriers between the parts. And these different personality states still have different ways of perceiving and relating to themselves and the world. However, unlike people with DID, the other personality state doesn't step in and take control. So another analogy of what this is like is the personality states of partial DID are more like ghosts. They exist in the past. They don't have a solid enough form to actively navigate daily life in present time. However, if you're in therapy and you're doing trauma processing, then you might actually see the different parts during trauma processing, and they become sort of embodied during that time.
So, Marianne, this what I'm lots of questions coming through. I wonder if I can put a few to you.
Yep.
What I'm noticing is that there are lots of different diagnoses. And Benjamin asks on the chat, what are the benefits and risks of going down the formal diagnosis path when someone's already in treatment, and they, the client sort of already knows there's a little bit of dissociation. Like, yeah, formal diagnosis. What's your sense about the benefits or risks of that?
I think it's really hard for people to accept a diagnosis often. So like more of the the psychoeducation around what's happening for them. But I think the diagnostic frameworks, it helps understand what's going on for them and what you might expect to see. So like just in this separation of DID from partial DID, knowing that there's probably a different level of risk. So if a person has DID, then they don't have awareness of, unless they've done quite a lot of work on communicating across parts, what's happening for them. So like even keeping themselves safe, like understanding what is it that I, did, and, waking up to situations where they're not able to have that safety or self knowledge in the same way. So I think sort of understanding, well, where on the spectrum are we helps guide treatment, but it depends on what the person is after. But I definitely think diagnoses aren't necessarily, you don't necessarily have to tell people. Some people would want to know, and some people really want a diagnosis. We'll be talking about that as
Well,
well.
on people wanting a diagnosis, Kate asks, how can we validate whether dissociation reports from a client are authentic? Do people sometimes fake it for personal advantage or for other reasons?
we're going to get into that. We're going to do a
Okay, all
deep
right.
dive into that. So that, like in our first case, we're going to look at as a case of dissociative identity disorder, and then look at some of the controversies around that.
All
Yeah,
right,
and
great.
different interpretations, and unpick that. So just quickly, the most common diagnosis is probably dissociative amnesia, and we're probably often seeing that with PTSD. And again, just remembering that you're more likely to see the partial DID than full DID. So we're going to start getting into the mid and the mid 60, and what is it? So I often get asked a little bit about this. So the original instrument was an incredible piece of development by Paul Dell, 218 items. It's considered to be diagnostic, but I still think it's important to check in. It's got validity scales including borderline personality disorder, psychosis, and rare symptoms, which can be really helpful. Although we also have to remember that for people with dissociative identity disorder, probably around half will also have borderline personality disorder, meet the criteria for that as well. And so it actually looks at dissociative identity disorder, partial DID, other specified dissociative disorder type 1, but I'll just say partial DID, and PTSD. So the mid-60s derived from the 5 most predictive items from the full diagnostic mid. So it's a screener, doesn't have validity scales, but one thing that I've managed to do is actually get it to pick up dissociative amnesia, again the most common, and depersonalization and derealization disorder. So I think that's a bit of a win. People most often use the DES, and it's really great for dissociative identity disorder, and that's exactly what it was developed for. It wasn't developed for all dissociative disorders, and so what happens is that it misses 96% cases of dissociative amnesia, around 75% of depersonalization. So if you suspect, that it's DID, DS, that's really great. But that's been a problem with it, and just if it doesn't really capture the symptom-specific questions on it, then that's one of the reasons that I actually made the mid-60, is that the DES just didn't seem to capture dissociation or dissociative disorders as a whole well enough. So what we're going to do in this next part is have a look at dissociative disorder symptom patterns, and just quickly going back to that, we have just finished our clinical validation study, and thank you so much, Ben and the team at NovoPsych. So we've got sort of a big 13,000 sample, and it's looking really good. So because it was first just validated in the university population, but we've done a lot of research with it since. So these are the scales, and it's good to get a handle on them because it will really help with your interpretation. For screening for dissociative identity disorder, I focus specifically on amnesia for recent events because that is a symptom that doesn't exist in the other diagnoses. So these can be really troubling experiences where a person is waking up to find themselves coming to, and they have no recollection of how they got to be in this place, in this moment. And so not having any memory of what's happened before, and this isn't just the staring into space. It's like, oh, I'm in the supermarket. How did I get here? Oh, why am I driving to my grandma's house? How is this? So it's like this coming to in situations and not understanding that linkage and having that memory gap. So it's like much more than just having a poor memory of, oh, I can't really remember what I ate earlier in the day. this is more significant. And so then we have to look for ones like types of experiences that could be partial DID or full, like, or that sounded terrible, or full DID. So there's the subjective awareness of self states, and that's a person having a sense that they have parts that aren't them, like this ego dystonic sense of parts. But again, not all people, that can sometimes take a bit of time for people to actually have that awareness that they do have parts. It's not always there. Angry parts are really predictive of dissociation, so the feeling of being taken over, and it's often because, particularly as children, they were never allowed to be angry because that would inflame the situation, lead to more trauma. So it's something that was dissociated away. So they have persecutory intrusions. So this is very much like a really hyped up, nasty inner critic that's, insulting and belittling them, and often telling them to hurt themselves as well. So we talked about derealization and depersonalization. So there's a subscale for that. For dissociative amnesia, there's the circumscribed loss of autobiographical memory. So this is where people can't remember much about their childhood or significant events. So that's like very classic in there. There's one distress about memory problems, which is sitting under dissociative amnesia because it is a bit about that, but it used to be a DID subscale, but it's too common. It happens, lots of people with all sorts of dissociation and other diagnoses seem to have these experiences as well. Even in depersonalization, we get this. So people may not be as present for a number of reasons, and a big one that we've found is ADHD. So people with ADHD score incredibly high, unsurprisingly, on this scale. But there's a lot of reasons, so we have to look at all of this in context. So people with DID and partial DID will pretty much always meet all of these scales. So then we have the ones that are related, or I say related. Flashbacks are actually a classic dissociative symptom. We just don't sort of talk about it in that way, but it's this sort of taking away the experience out of time, and it's coming back. So it's a sort of disconnected, dissociated experience. We assess for flashbacks for our PTSD scale, and then we have conversion disorder where we're looking at body symptoms, and that can be like where a person can't hear for no known medical reason, feels paralyzed. So these somatic symptoms. And psychogenic seizures is just a weird one. It just ended up in the factor analysis being its own thing, but it's as well, it's part of conversion disorder. And it's often linked to trauma, but it doesn't, a person can have conversion disorder without the seizures being there as well. And then we have self-confusion, which is the culmination of all of this. And people with dissociative disorders have a chronic sense of self-confusion about who they are. And we also have to remember that other people can have a sense of self-confusion as well that can make that scale quite high. So on its own, that's why it's called a general subscale. It doesn't mean as much on its own, it's more in context. So if you had a person that was from, for instance, from a migrant background, so had lots of different sort of identity clashes there, and that also non-binary, and there was like a little bit of confusion there, that so it sort of all builds together, and you could have like really high levels of self-confusion even if you didn't have depersonalization. Sorry, even if you didn't have a dissociative disorder. And trance is where people are non-reactive to the outside world and just in their own little world. And that could be lovely, enjoyable daydreams. It could be a state of total emptiness. It could be ruminating about traumatic events. But yeah, just in this trance-like state. So we are going to get started with our first case study, and just looking at the time. So I think we should be okay. So Laura is a composite of 30 women receiving treatment, both inpatient and outpatient, for a complex dissociative disorder. So she's 45. She was sexually abused from a young age by her father, her brother, and uncle, and community members of the religious organisation her family belonged to. She experienced frequent physical violence from both parents. Her mother never showed any affection, and her father was intensely abusive, but it could occasionally be kind to her. Although she was always daydreaming, Laura did quite well academically at school. She married young and had 3 kids, but her husband Len was violent and controlling. Although she found it hard to accept that Len was like that. Len would say she gave as good as she got, but she would never know what he was talking about. What was it that she was meant to have done? And now her kids are older. She works in a childcare centre, and she tells you that she has a 6th sense for knowing which children are at risk. She admits to you that she's drinking too much, taking Valium regularly to quiet. She calls it her noisy head and is a bit evasive about it. And she tells you she's got a lot of shame and embarrassment, that she forgets what she's done and even the people that she's meant to know. Her teenage kids says she acts like different people, and they sometimes make up crazy stories about her, and it baffles her why they would say these things, as it's hurtful and not funny. And she wishes they would be more supportive. This is very exciting. In the new release of the Mid-60 on NovoPsych, it now actually works out the most likely diagnostic profile. So we actually have here dissociative identity disorder, which is fantastic. And it also, of course, can track across time. So in the clinical percentile, which is based on complex dissociative disorders, which is around half, but in a community percentile at 99th percentile. And she has a score of 57, which means dissociating roughly equates to dissociating 57% of the time. So the majority of her working day, Laura is experiencing dissociative symptoms. Also in the new release, we have this fantastic flag about the items that we really want you to focus on to ensure your clients are safe. So in this one, she had reported that she hears a voice inside her head that wants her to hurt herself, and that's quite strong, 5 out of 10, and that wants her to die even stronger, and that she has actually had at least some experiences of waking up and finding that there's something like pills or a razor blade that she could hurt herself with in her hand. So that obviously needs to be addressed as a priority. The way that it's outlined now, it actually will talk about the profiles that, like, what is it that led to the classification of dissociative identity disorder in this one. And it's because of the persecutory intrusions. And you can see there, like, the voice in the head about shutting up, not being good, a voice that calls the names. There's definitely a subjective awareness of self-states that hasn't come out in what she said to you in therapy yet, but she does have a sense that there are parts inside. So that might be the noisy head. And we've got angry intrusions as well, and amnesia for recent events. And this gives some of the ideas of some of the things that do happen for people with dissociative identity disorder. So, you know, discovering that you've changed your appearance with no memory of having done so, finding yourself somewhere odd at home, inside the closet under a bed with no knowledge of how you got there, finding yourself somewhere, beach, work, nightclub, with no memory of how you got there. So, you know, these are incredibly specific and strong symptoms. And then it also tells what other clinically significant domains there are. But when we look at it, like, Laura is very strong on everything. So the items that are in the clinical range is all of them. and everything is in the clinical range on this for Laura. So, and I was saying about self-confusion, with all of that going on, you're going to have a really high level of self-confusion. So that actually is the highest, and the loss of autobiographical memory are the ones that stand out the most. Even though amnesia is a core symptom of DID, it tends to score quite low. So she's actually scoring pretty high at 30, like even over sort of 10, we would consider that to be important. And another great thing in the new release of the NovoPsych is that we're now grouping the subscale, so you can actually get a good sense instead of just seeing all the items in order where they're all mixed up. And when you look at this, you're like, oh, all threes. Is that like they're just picking the same number? And because sometimes you can see patterns in questionnaires, but when we look through all of it, there is variation. And it also makes sense that because they're subscales, they say stay in a sort of similar-ish range. And we can see there's, clinically, and in the pink bit here means it's clinically significant. So for this item, even one is clinically significant, where the next one isn't considered clinically significant. So you can get a sense about where your client is scoring. Are they well into that pink range, or are they at the cutoff? And we can see that lots of derealization, distress about memory problems, and autobiographical amnesia, flashbacks. Body symptoms tend to score low. They don't happen that often. So they tend to score on that sort of, around one or two if it's clinically significant. And again, every single item is in range. So the little grey that I put here is just the clinical cutoff for a dissociative disorder, not for DID. And you can see that Laura's tracking well above that across all the scales, except for seizures being similar. One thing people have asked me about is also the adolescent MID. So we've had that out for a couple of years now, and we're doing a validation study on that that's looking really good. I think it's a few thousand adolescents in that study. But they do have by far, we start at 18, but their rates of dissociation are really high. But what we can also see here is that it seems to be fairly similar there for males and females, the rates, but for people who are coded by their clinician as being non-binary other or non-binary trans in the update, then they're actually scoring much higher again. So it made me think, what would this look like in a young person? And so I took profiles. So this is nearly 300 adolescent females with profiles that are consistent with dissociative identity disorder. And I mapped that against Laura. And what's really interesting is it's really the same. So this 16-year-old is experiencing really similar symptoms, except for the self-state awareness. And it might be that their self-states aren't as developed yet, but yeah. Or that there's not the awareness of them. That could be the other part, that there's like too much amnesia at that point, because the need to not know, and that's why they have dissociative parts, is to, little soldiers to get through this incredible trauma, and they can't know. So it might be that the amnestic barriers are just really, really strong at that age. And otherwise, it looks again really similar, except for more somatic kind of body symptoms in Ella here, our composite 16-year-old. So dissociative identity disorder is really important when we think about the fact that 72% will attempt suicide and 2% will complete suicide. I think that figure actually also includes people with partial DID for the completed suicides. 96% have a history of self-harm. 90% with PTSD, more than 90% with major depression, half with substance use issue, 35% with an eating disorder, at least, usually around half with borderline personality disorder. So there's a lot of other complex issues going on. Okay, so you think your client has a dissociative disorder. What next? There's structured clinical interviews that you can do. You can use the full mid 60, sorry, I said 219, that should be the full mid. And a lot of people think that they should refer on at this point, but there's a real lack of clinicians, and there's a lot of goodwill in the clinicians that know a lot about dissociative disorder and want to, do supervision to help people be skilled up so they can develop the competencies needed. And there's treatment guidelines from the International Society of Trauma and Dissociation and the Blue Knot Foundation, as well as a lot of resources as well. But seeking good supervision is what, ideally we'd like to see, and sort of building the capacity. So in other diagnoses, we're going to look at dissociative identity condition, which is like a false positive, which I was being asked about. What's the difference between ego states, partial DID, and false negatives? So dissociative identity condition, this has been talked about a lot by clinicians worldwide, and there's been like a dozen or so articles written on it in academic articles in recent years. But in recent years, clinicians are seeing young folks, often post-millennials, self-diagnosing DID. That in itself is probably fine, given it takes 7 to 10 years to be diagnosed. But this is just describing what they're seeing. But they don't meet the diagnostic criteria. And here are some of the common features that they see. There's often trauma histories and milder symptoms, but they don't cause the clinically significant distress or impairment. And it's like their DID accounts for conflicting needs, behaviours and impulses, and their feelings of self-confusion and their difficulties recognising their needs and interests and emotional state. They're generally able to present their history chronologically, which would be incredibly difficult for a person that's got complex dissociation to do. Even if they're highly distressed, they appear to present an altered personality and are comfortable disclosing the information about experiences of trauma. And no one should have shame about their dissociation at all, but people with DID have such crippling, intense, internalized shame about the intrusions and having dissociative parts. So that's a bit of a difference. They also may exaggerate, and this is something that's commonly reported, to receive a diagnosis, but then clinical interviews don't confirm the reported symptom severity. And that's why the mid-60 and tools like it can be really useful, because where people have scored high, you can just curiously find out, well, what, you've said you've woken up, on the beach or in a nightclub. Can you describe that experience to me? And so you're just trying to get a sense of, does this match what's being reported in the questionnaire? And there's often like a lot of education, and it's great for people to be really educated. There's so clinical terminology, but there's also a lot of the online wording. And again, this isn't any reflection on that. This is just describing what clinicians are reporting. So, talking about more plurals and systems and fronting and mates and this kind of language that's used in online forums. They often advocate for a DID diagnosis and may become disappointed or angry when it's not given, and may try to seek a diagnosis from a different clinician. Whereas for people with DID, it often takes many years to come to terms with not just the diagnosis, but the trauma that caused it, which is often incredibly extensive. They have elaborate inner worlds with rich details, and all parts of the system seem to have knowledge and access, and they know all the whys and the hows, and there's like a really good, like where the amnestic barriers tend to, unless there's a lot of work that's been done, tend to prevent that flow of information. There's also a lot of alters with extensive backstories of movies and video games. It's hard to know if this could just be like modern changes in the way a diagnosis presents, but it is quite different. And this is particularly striking, is that instead of being phobic and afraid of their parts and their inner world, which is generally the experience of people with DID, particularly in the beginning stages, they might find working with parts enjoyable or soothing, which is quite the opposite. And the dynamics between the alters are different. Like they might have families and homes, pets, friends, and even babies in the internal world. And it's not related to anything specific in the trauma history. And it's been proposed that this might be better described as maladaptive daydreaming, which Eli Summer sort of coined this phrase and has done a lot of research around that, where people often use stereotype movements and immerse themselves in this like really intense fantasy world, often to music as well. I probably need to move on a little bit, but these are some of the sort of alters that are seen in DID systems. All systems will be different, all different parts, but there's, generally going to be, the child alters like a helper alter. So, and one that sort of the perpetrator is likely to be in there as well, and persecutory ones. So yeah, it's like, how does the system look and function? Is that similarities? And it doesn't need to be completely similar, but does that sort of make sense? So a person could have many features that look like dissociative identity condition, where you're saying it's probably not DID, but they may have DID. So this is about being curious and asking more questions. And people with DID are often very fantasy prone and do like living in, like, the fantasy world's been a great escape for them. And that might provide sort of a scaffold for more structural dissociation. And there's also issues about just living online. Does that make us more dissociative as well? And there's also ego states versus dissociative states. So it's really interesting when you look at the wording and just try to actually find the difference there. So for people that do ego state therapy, an ego state is an organized system of behavior and experiences whose elements are bound together by a common principle and which is separable from other states by a boundary that is more or less permeable. That's really important. Where the boundaries become rigid and impermeable, we call that a dissociated ego state, which in its extreme form may become an alter of a multiple personality. And so that was Watkins and Watkins from ego state therapy, writing back in the 90s. And this, like, ego states are personality energies that are born of interactions with the environment and often arise from the need to solve problems or meet conflicts. Each ego state has its own relatively enduring affects, bodily sensations, thoughts, memories, fantasies, behavior. Each ego state has its own wishes, dreams, and needs. They relate to each other much as a family would. Although are separated from one another, they engage in transmission of information, role assignment, cooperative ventures, sharing of goals. As in families, there may be subgroupings, alliances, hostilities, and conflicts. But this is what it does sound like when you are actually looking at the descriptions of some people that have dissociative identity condition, that it's probably more likely to be ego states. And it's just about how strong is the barrier. So in this article, they say in false positive dissociative identity disorder, the inner characteristics described by the client are personified unintegrated ego states, which evoked conflicting feelings. So that's what they're sort of seeing in the research. Won't go into it too much, but internal family systems, we have dissociation as a firefighting technique for people that are in IFS. But even in IFS, they talk the alters of clients with DID are parts, but their inner systems are more polarized and disconnected. This is because horrible childhood abuse causes vigilant protectors who rely on amnestic barriers, which block the usual web on inner relationships. So what we need to know to see if it's DID is there evidence of current or previous amnestic barriers between some or all of the parts of the person. And then we have the opposite. A lot of people don't want to have a dissociative disorder, particularly dissociative identity disorder. And a lot of people just don't realize they have it themselves. They think that everyone is just like them and has voices in their head and doesn't remember their childhood and has problems with their memory. And we reinforce that by the things that we say. You know, it's like, oh, part of me feels like this, and I don't know whether I'm Arthur or Martha. I've got a mind like a sieve, and just this ongoing way that we talk can normalize this and lead to underreporting of it. There's also this fear of being seen as crazy and being institutionalized, and often the fear is being misdiagnosed with schizophrenia. So this is Kylie, and she's saying, I wasn't going to tell them I had voices. The psychiatrist asked me if I'd filled out the DES, and I said I had. She asked if I was truthful. I said no. When asked why, she said, I don't want to have schizophrenia. She said, it's not about schizophrenia. Can you just fill it out and be honest? And I did. And she came back to my bed, an inpatient, and looked completely shocked and said, that's pathological. Probably not the best thing to say. Then she tried to explain what dissociative identity disorder was and asked how many people I have here. And I was still confused and I didn't know what she was talking about. And that's often how it is people with dissociative disorders lack awareness about the extent of what is buried. So Sebastian, a PTSD profile, and again, this will just come up with that. So I might go through, but what I really want to talk about with this one is just that idea of we have to work out what kind of diagnosis to give. And this one was a person that, and so you can actually go through this you've got my handouts and have a look. But the fact is that this is a person that we need to work out if their dissociative amnesia is related to the trauma they came to therapy about, which was an assault, or whether it looks like there's more complex childhood trauma where we might need to give an additional diagnosis of dissociative amnesia. So, and we had Jessica, who had had a really difficult time growing up with autism and being bullied and excluded. So there's a case story of her in a relationship that was abusive that she didn't realize with her support worker. And her dissociation score looks like it's other specified dissociative disorder. So you can go through this case study and have a look and see how that goes. Again, like flagging the risk of self-harm or suicide, and very similar to what we see in DID, where there's a whole lot of subscales endorsed across the board. It's just the amnesia, and so that's the really clear one where we know that it's not DID and that it's other specified dissociative disorder. And I also wanted to say that people with ASD can often find it a little bit hard to use scales from 0 to 10. So if you get any really strange scores, you might want to find out about that. And we also might want to know a little bit more about the experience of parts and where camouflaging fits into that. Like, is that self-state, does that feel like a part that I have to get through life with that's not me? And there's so many risk factors for high rates in ASD. got such high rates of trauma. It's really difficult living in a world that's not being built for being an autistic individual. There's often not access to meaningful and effective protection for recognizing abuse, and also what actually heals people, what's the most effective therapy. There's a lot that isn't known about recovering from trauma. And there's also, a potential overlap with dissociation and autistic experiences around sort of the camouflaging aspect, as well as there's issues around autobiographical memory is slightly different, which also may make the memory, those memory items a little bit higher, might be due to that. I did a gender diverse composite just because the rates are incredibly high. The cutoff is in the range of, this is very much complex dissociative disorders on average for people that were coded by their clinician as being non-binary or transgender. And we know that there's these really high risks for dissociation, particularly if they've experienced emotional neglect. It's this 12-fold risk for dissociation, much higher than for other females or males, and emotional abuse as well. So we know that there's a lot of trauma history too. So I'll just quickly show you where it looks compared to dissociative identity disorder. And this is just pulling out all the average, sort of the median for each of these age groups who had completed the mid-60. And what we see is, although I put Laura, who's our DID person, in red across the top, just to give you a reference point, but we can see just how high it is. So for our 16-year-old, that is actually in the dissociative, that would be a DID diagnosis. And it's not for the 19-year-old or the 25-year-old profile. But yeah, it's really showing that for those young folks, they're likely to be scoring in the dissociative identity disorder range. And interestingly, they scored even higher. So remember, Laura is our DID person here, was scoring even higher than her on flashbacks, trance, self-confusion, and body symptoms and seizures. And this has some pretty important implications, because it's, we know that in DID, around half people have opposite sex alters, and that can contribute to dysphoria. In this case, it's going back to the 1980s, where people underwent gender affirming surgery and they were dissociative, and then were completely shocked about what happened because they didn't have communication across parts. So there's an issue around diagnosis that needs to be looked at. Yeah, so it's a really complicated issue that does warrant attention for people that are transgender, non-binary, and gender non-conforming. Just with all, this is all the subscales for the 16-year-old composite, 19 and 25, and you can just see that there's across the board really, really strong symptoms there. But we also know that people with those experiences have also experienced so much trauma on the whole as well. And of course, that leads to dissociation as well. So trying to unpick that is going to require a lot of care and compassion and understanding to get to the bottom of it. So my final slide is, if you're working with clients with a history of complex trauma, you're working with clients with dissociation. Now, if I can stop sharing.
Marianne. I mean, the depth of knowledge that you've got is so obvious, and I think that some of those slides have so much wisdom on them. And we got lots of questions. I'm going to put a few questions to you, and there's 3 questions here that are all similar. So I'm going to ask a 3-question one. Christina says that she's got clients experiencing MCAS, that's mast cell activation syndrome, POTS, postural orthostatic tachycardia syndrome, and dissociation with burnout. And this is really indicating neuroinflammation. How do we get the right diagnosis for this? And is neuroinflammation associated with dissociation? Another question. I told you I'd give you three in a row. Cecilia says, what is the current evidence for the relationship between autonomic nervous system dysregulation and dissociation? And Chrissy asks, can dissociation be related to an underlying medical condition without complex trauma? So I suppose that all of them are about, is there some sort of autonomic nervous system dysregulation or other medical issue without complex trauma? And what's your sense of that?
Look, I mean, I think that there's often is a trauma story with all of these diagnoses, and we seem to see that, and a lot around inflammation, a lot around medical syndromes, that it does seem to be part of that. I'm not in that world of research to be able to answer the question definitively, but I'm sure that we would see risk factors. People can dissociate because of how difficult their physical symptoms are. Like, I do believe that, and the same I think with autism as well, with the overwhelm, and so where it wouldn't be a classic capital T trauma, I still think that it can occur. So if people are in chronic pain and like that idea that it's overwhelming your capacity to cope, is that something that you would do to dissociate? It does make a lot of sense,
So
but
it's
I
more
think
like,
that
and so one pathway just on the causality could be that trauma is linked to neuroinflammation, which is also happens, and the trauma is linked to dissociation. And so these things might go hand in hand, but it's not just the medical condition that's causing dissociation. It's the trauma causing body problems at the same time as causing dissociation. Have I got that right?
well, I think that we have to do a research study on it,
Oh, we
maybe.
have to do research. All right. So like
Like there
true
might be
research.
some research, but I mean I am starting to see these, and on the clinician forums I am on, these like POTS and things that comes up so much with dissociative disorders, but also in the context of a lot of other things going on as well. So it can be
Mm.
really hard to unpick these things, and I think it's really good that these clinicians are being so curious and
Yeah.
open-minded, and yeah.
So a question here, how does persecutory parts differ from psychotic symptoms? And do lots of people with get diagnosed with schizophrenia accidentally?
Yeah, absolutely. So a lot of people with dissociative identity disorder will have been diagnosed with schizophrenia. So the voices are often like they might be a perpetrator kind of voice from somebody that has been in their life, and it's very much trying to keep them small, on track. So wanting them to hurt themselves. Not necessarily, I don't think we really hear of hurting others. It's usually turned inwards, so it's persecuting the person themselves.
Mm.
Um, but we know that voice hearing is more common in dissociative identity disorder than it is in schizophrenia. So yeah, there's really a lot of good work being done on trying to unpick that. If you look at the work of like Eleanor Longden, Martin Doherty, so where they're trying to find that difference between psychosis and dissociation, because trauma is actually often underlying both as well. Like trauma is childhood trauma is a massive risk factor for schizophrenia too.
Mm.
So often, like whenever I do research, sadly, that's what we're finding. It's those early years, like stress and trauma in the early years and attachment issues that do seem to be driving a lot of mental health
Mm.
concerns.
Another question here. Symptoms to recognize in therapy. So, when someone walks into the therapy room, they're not necessarily going to say I've got dissociation. It's going to be up to the therapist. And also a couple of do's and don'ts in therapy when working with dissociation.
Yeah, that's an interesting one because I'm a researcher and not a clinician, so I can't answer that. But what I would say is the majority of clients, the majority of therapists don't pick it up.
Yeah.
And so it's often the sort of trancing out, sort of like, I think when people get the training of it, they know what to look for and they start to see it. But this is where I'd really recommend that people start getting engaged and getting trained in working with clients with dissociation. But the most important step that we're doing today is for you just to identify it's there. And the reason we have these screeners is because people don't pick it up, because people don't talk about it, because they're ashamed, because they don't understand. So there's all these reasons. But if you actually give a person a screener, then they're like, and they'll often say, why hasn't anyone asked me that before?
Exactly right. And so while the majority of clinicians won't pick it up, not because, for no fault of their own, the mid 60 and other measures will pick it up, most of the time. And so I think, while therapy is an intrinsically human process, it turns out that some of the technologies we have available, like exquisitely produced psychometric questionnaires, can do some things, like identify some problems, much better than clinicians. Marianne, thank you so much for tonight's webinar. It's an absolute a pleasure to hear you speak and condense all of your wisdom, or try and squeeze all of your wisdom into a presentation like this. I really appreciate it. And it's also been a pleasure, the research collaboration as well. So thank you for that. And thank you.
Absolutely, and thank you. And thank everyone for coming to watch and listen and learn. It's really exciting to have so many people interested, and we just really need to build that knowledge. And there's great resources out there, and Australia has some, fantastic clinicians working with dissociative disorders that can share their knowledge.
And thank you everyone for coming. I think you coming is a testament to the commitment that you have to improve the way we all practice and the way we all approach dissociative disorders. I'm at NovoPsych.com here. If you'd like any further information about the mid-60, you can head up to the assessments page and type in the mid-60. I always find a really great way to learn about an assessment is to self-administer it, because it means you know the questions, you know what the output is going to be, and you can do that by pressing administer now. If you've enjoyed tonight's webinar, you might enjoy some of our other webinars that we have available, including the maladaptive schema scale, eating disorders, and some shortcomings of the DSM-5 and death anxiety. There are so many good ones here. Do have a look at them. They are all freely available for you on our website.